Hi everyone. This is the fourth episode for our antibiotic review by Dr. Oliver. In this fourth episode, we're going to talk about urinary tract infections and some of the antibiotics that we'll use in this particular system. Now, just like the previous episodes, I'm hoping that a lot of this is more so a review for you. You can always refer back to your previous modules to get more in-depth information. But first we're going to start talking about a urinary tract infection. So this is a broad term. It's used to describe any sort of bacterial infection of the urethra, bladder, or kidneys. And we usually classify that as complicated or uncomplicated, and so that's important to remember when you are recording a past medical history. There's lower UTIs and then upper tract infections, such as pyelonephritis or a renal abscess, and so these are also important to differentiate when you are taking a past medical history or treating someone and you're wanting to know what their past GU history is. These are important to note. The urinary tract is the most common site of hospital infections, and many are hospital-acquired infections due to indwelling catheters. So it's important, if you do end up working in the hospital environment, it's important to make sure that we're getting those catheters out as soon as we are able. A hospital-acquired UTI increases the length of stay by at least 1 day, if not more. And then more than 100,000 hospitalizations per year are due to UTIs. It's important to understand what the difference is between uncomplicated UTI and complicated, so this is just a little list for you to just describe the differences. An uncomplicated UTI is most common in the outpatient realm. This is a cystitis or a pyelonephritis. It typically is occurring in healthy, non-pregnant, or ambulatory postmenopausal women that have an anatomically or functionally normal urinary tract. So these are your people that you probably are not seeing very often for UTIs, and this is just kind of a once in the blue moon infection for these people. A complicated UTI, however, is all other individuals, especially those with already an indwelling catheter, if they've been in the hospital and if they're in a nursing home or if they have any anatomical issues. Also pregnant women as well too, as we learned in one of your first modules, they are more prone to UTIs and we do need to treat those. When you're diagnosing a UTI, your biggest way to diagnose would be a urinalysis. So diagnosis can be made by the presence of bacteria in the urine from a clean midstream collection, and then you're also going to make note of what symptoms they're experiencing. So are they experiencing any urgency, any dysuria? When you're looking at the urinalysis, you're looking for greater than 10,000 colony-forming pathogens for a diagnosis of acute pyelonephritis or a bacteriuria, so a UTI. Dipstick urinalysis is frequently used just because of the cost and fast results. You'll see those a lot in urgent cares just because patients don't have the time to be spending there waiting for that urinalysis. There really should be a compelling reason to obtain a urine culture. So if you have somebody that comes in and they say that they're just peeing a lot, you may need to do a little bit better history to figure out if that urinalysis is actually needed. You might actually end up treating them for something different, like maybe a new onset diabetes for that. But if they come in and they're having flank pain, or they're having suprapubic tenderness with palpation, or they're complaining of dysuria or burning, then that would be a compelling reason to order a UA. And those things need to be documented as well too to back why you are ordering something. So any foul smelling or cloudy urine without any other signs or symptoms is not necessarily a reason to order a urine culture. A lot of the times we go ahead and we will order a reflex culture. However, in the outpatient realm, if you have somebody that keeps coming in with these UTIs and you know their history, you may not necessarily always have to order a urine culture. However, that also goes, I would say, per provider as well. So in the hospital, I am used to ordering these cultures, but I would say not everyone orders a culture outpatient unless they have failed a certain antibiotic and then they're having to come back for another antibiotic. I just wanted to briefly discuss some of the more common pathogens that cause UTIs. E. coli causes about 80% of all of the community-acquired UTIs and about half of the UTIs in the hospital. I did include some other pathogens there, like Klebsiella. I know a lot of you have probably heard of that, or Proteus. E. coli is becoming increasingly resistant to Bactrim, to where it's no longer a first-line agent, which is unfortunate because it does limit us, and that's another reason why we need to be good stewards of our antibiotics. Quinolones are used for complicated UTIs. However, there's also resistance seen with the quinolones as well. Beta-lactams are associated with about 40% resistance rate for E. coli. And then nitrofurantoin has low resistance, but has little use beyond the urinary tract. So if you're also treating an infection elsewhere, it's not really a good choice because you are literally only going to get coverage in that urinary tract. So before we start talking about antibiotics, it's important to talk about prevention. This is extremely important to talk about with women as well, because women tend to be more of the ones who end up getting the UTIs, especially your younger women, middle-aged, pregnant women. Men typically are found to get UTIs later on in life. It's not as common for them to get UTIs earlier on in life. So when we're talking about prevention of UTIs, we want to avoid products that may irritate the urethra. You want to encourage patients to cleanse the genital area before and after sexual intercourse. For children, change soiled diapers for infants and toddlers frequently. We also want to encourage our patients to drink plenty of water, not to delay the urge to urinate, which as nurses, we all understand that sometimes that's not always possible, but we want to make sure that we encourage that. And then, of course, we talked a little bit about it, but we want to remove catheters as soon as possible. Some people will talk about herbal remedies. Cranberry juice, you can use that. There's a couple of other ones out there that people will use. Really, we want to get people to pee, and we want to dilute the urine so that we can dilute that bacteria and then flush it out. So that is the main purpose of a lot of those herbal remedies. Cranberry juice really is, if someone does not have diabetes and it's not going to cause their sugars to spike, which can also make the UTI worse, then I would say if they want to drink cranberry juice, that is more than okay with me. Now we'll talk about asymptomatic bacteria. So this is greater than 100,000 colony-forming units. It's often used as a diagnostic criteria for positive urine cultures. It does not prove an infection. It is just a number to state that the culture is unlikely due to contamination. It is the presence of symptoms and pyuria and bacteriuria that denotes an infection. So if someone does not have symptoms, they could possibly be colonized, and so that's something important to think about, especially for people that get these UTIs frequently, because they have a high probability of being colonized. So no adverse outcomes associated with asymptomatic bacteria in older adults, and there are no benefits associated with antibiotic treatment necessarily. So asymptomatic bacteria should not, however, go untreated in women that are pregnant, anybody undergoing urological surgery, or anybody that has received a kidney or pancreas transplant. That is important to remember. Now we'll go ahead and talk about treatment with cystitis. So if there's no suprapubic pain or dysuria, antibiotics are not necessarily needed. Foul smelling or cloudy urine is not a symptom of a UTI. Sometimes that can be due to foods or dehydration. I don't know if you guys have ever heard, but asparagus can actually make your urine smell pretty badly as well. So it's important to get that 24-hour diet recall from people, because that might be a factor. You want to have them increase their fluids. Macrobid is the first line choice for most women. It's also pregnancy safe. And typically we do a 5-day course of Macrobid. You can do a 3-day course of Bactrim. However, Bactrim cannot be given to women that are pregnant. And if there is a great local resistance, Bactrim is not necessarily encouraged. You also want to make sure that they're not allergic to any sort of sulfa drugs, because that allergy tends to be a little bit more popular. If E. coli resistance is suspected, then a fluoroquinolone such as Cipro at the same time duration is acceptable. So you would do Cipro for 5 days as well. Other options include a single dose of the fosfomycin, although I don't see that as commonly used. I would say probably more your Macrobid, your Bactrim, your Cipro are the more common ones used for a simple cystitis. Now we'll talk about a complicated cystitis. A wide range of bacteria can cause this type of infection. Typically, the fluoroquinolones are a good first-line agent because of their broad spectrum. For hospitalized patients, initial therapy may include an aminoglycoside or a third-generation cephalosporin. We do use Zosyn a lot. Meropenem we don't use quite as often unless they are, we know that they have had certain types of bacteria before, so they've had recurrent UTIs and they've had to be hospitalized before, they've had to receive IV antibiotics before, and typically when we order meropenem, we do automatically order an ID consult as well. In the hospital, I would say our first line, and this is, I actually just went to an infectious disease course. When was it? It was about 3 months ago, and it was actually really interesting. It was through PESI. If you guys have ever done any of their, they usually have one-day seminars. They're really good. You can go on PESI.com and look at some of them. But their infectious disease right now, what they were saying in that seminar, that the first-line agent for a complicated cystitis and the patient is hospitalized is IV Rocephin. So the expected length of therapy is about 10 to 14 days. It doesn't necessarily mean that they're receiving IV therapy that whole time. They can be switched to oral antibiotics depending on their overall clinical improvement and their ability to tolerate oral medications. Let's talk about UTIs during pregnancy. So in about 20 to 40% of cases, UTIs during pregnancy are a progression of an asymptomatic bacteriuria. So more likely to be a complicated UTI, and it can progress to a pyelonephritis, so we have to treat these patients. The safest antibiotics to use during pregnancy are amoxicillin, Augmentin, Macrobid, and Keflex. Macrobid is your first line. Keflex typically is probably the next more commonly used antibiotic. Duration of treatment, it can range. It's important to look at their history. Have they had a lot of UTIs in the past? How far along are they? Do these women, are they experiencing a lot of symptoms? If not, then we can talk about a 3-day course if it's caught early. However, if they are having a lot of symptoms or maybe they have a significant history for UTIs, then we can look at a 7 to 10-day course. Lastly, we'll talk about acute pyelonephritis. Most of these patients do end up being hospitalized because it can progress pretty quickly. Fluoroquinolones plus an aminoglycoside are the good first-line agents. You can also, again, use that Rocephin. And then for acute uncomplicated pyelonephritis, therapy usually ranges anywhere from 7 to 14 days. However, if it's a complicated pyelonephritis, we can even look at 14 to 21 days. And those are typically people that have a poor immune system, people that have had frequent UTIs in the past, or maybe they failed multiple antibiotics for their UTI. Those are the people that we're going to be looking at for a 14 to 21 day course. And usually ID is involved with that as well. For the acute uncomplicated pyelonephritis, we actually see a lot of those in the hospital. And I would say, they'll be on antibiotics, IV antibiotics for about 2 to 3 days. And then at that point, usually the goal is to transition them to oral antibiotics. And then we would send them home with the rest of the course to give them anywhere between 10 to 14 days total. And then it is important to de-escalate when possible. And so that's why the culture is important, to get that done first when they first come in before they've started antibiotics. And it's also, it's important to look at the overall patient. If at that point in time we can de-escalate the antibiotics and still have them on something a little bit more, as we would say, softer, a softer antibiotic that isn't the big gun antibiotic, if we can keep them on that but still provide them the same coverage, that'll be better if they end up having more events later on like this, because then we can bring in the big guns when we need to later on.